Hey, Jared, great stir up here. I have Tamara Murphy is going to talk to you about what she does. Tamara, thank you so much for meeting online with us.
All right. Hi. So I am Tamara Murphy, and I'm going to speak to you today about being a physician assistant. That is what I do. So this is my first virtual presentation. I'm excited to do this with Mr. Steer up here. So thanks for doing medical careers. I think this is a great program, and I hope to give you another nugget of information about what I do in medicine. So I'm a physician assistant, and being a physician assistant is also called being a PA, and it's an alternative to the traditional medical school. So the physician assistants are a group of people that were historically, we came out of the military, we, the profession, not me personally. We're not a physician assistant who is part of the physician's team that he or she owns. It's our own institution of being a physician assistant. Our profession came out of the Navy Corps, and they sent 4 classmates to the university at Duke and graduated the beginning of the PA program in 1967. The PA profession was created to improve and expand healthcare when there was a physician shortage, which ironically continues today. And so although that shortage started in the 1970s, we continue to be a large instrumental piece of the healthcare team. If you're serious about learning more, I know you'll all be able to Google and look stuff up. The pahistory.org, pahx.org tells a lot more about the history of the profession if you're interested in those details. So the future of our profession is very robust. Due to changes in healthcare the last several years, the Affordable Care Act, also known as the ACA, there's a projected need to double the amount of PAs in the next decade or more as healthcare needs of our citizens go up and the access becomes limited. Forbes and Money Magazine rate the physician assistant master's degree as the most desirable advanced degree in terms of employment opportunity, income, potential, and job satisfaction. And my understanding from talking to PA students right now is it's incredibly competitive to get into PA school, more so than medical school, because the classes are smaller and the demand is much higher. So what do? We do everything. I like to call it mini medical school without the debt that one would incur going to medical school, but we really do everything that physicians do. We do medicine, surgery, work in clinics, we work in hospitals, we work in freestanding facilities, we work in disaster areas, and we travel, if needed, to areas that are underserved that are working with institutions like Doctors Without Borders. So how do you become a PA? Most recently, there are 236 accredited schools in the United States, and that number continues to grow. There's a new school here in Colorado that opened just last year. I think that their class is on their 2nd year. There are 3 programs here in Colorado, one at the University of Colorado Health Sciences Center and the other at Red Rocks Community College, and they partner with a master's program out of state. And then the 3rd program is in the southern part of the metro area, is part of the new medical school out in Parker. Becoming a PA is a nationally certified degree, and we are licensed by the federal DEA to write prescriptions, and we are state licensed by the state medical board. So we work in all 50 states in the country and carry licenses both locally and at the federal level. I already mentioned it's highly competitive, and let's talk about the prerequisites. For those of you who are serious about medicine, you'll kind of see this list everywhere. For prerequisites in medicine includes all your hard sciences, chemistry, anatomy, physiology, biology, microbiology. Some programs will require specific healthcare experience. So you'll see programs that are looking for people who have, say, 500 hours or 1,000 hours or 2,000 hours of healthcare direct patient experience, whether that's as an assistant in a clinic, a hospital, or a surgery center, or a technician like a lab tech, a pharmacy tech, radiology tech. There's a lot of different things that people will start before they go to PA school. Most programs now require a bachelor's degree because PA programs are at the master's degree level. Some of the PA programs combine the bachelor's and master's degree depending on which school you go to. The school programs are typically 2 to 3 years, and that would be after your undergraduate prerequisites. So if you're looking at a traditional model of after high school, you have 4 years of college, and then you have a 2 to 3 year PA program. That includes all of the classroom didactic instruction and the clinical rotation. So there's no additional residency program after your 2 to 3 year program. Whereas in medical school, you have your 4 years of medical school followed by a residency program. PA school is one thing all together. So how to get healthcare experience? I mentioned being a technician. There's also EMTs and paramedics who go on to PA school. RN, CNA, MA. So we live in the world of acronyms in healthcare. So RN is a registered nurse. CNA is a certified nursing assistant. MA is a medical assistant. So you can become an MA, I believe, at the age of 18. There are some states that do have programs starting at the age of 16. Medical assistants are really the assistants to certified nursing assistants who are also assistants to registered nurses. Other healthcare experience would be through the Peace Corps, phlebotomist, which is a lab technician who draws blood, the ER or emergency room, radiology or surgical technician, and those people usually have a specific on-the-job training or certificate program to be a technician in their field. So to give you a little bit of a more personal experience from how I got to where I am, I call being a PA my third career. My interest through my younger life in middle school and high school was I really wanted to be outside and work in a place where I didn't have to get dressed in a business suit for work, and I would have flexibility in my work environment. So I started as a lifeguard in high school and a ski patroller in high school. And then I went on to become an EMT and then eventually a paramedic. I worked as a ski patrol outside of Colorado before I moved here, and then also here in Colorado, and I still continue that today. And then I worked as an EMT in a rural mountain community before I became a paramedic. And then I worked as a paramedic in Denver at the former Denver General Hospital for many years before I went to PA school. I did go to college, I had all my prereqs. I had a major in biology and chemistry, so I covered all the hard sciences as part of my education before I went to PA school. I worked as a 911 paramedic for 17 years before I went to PA school, so my first career was really in the pre-hospital wilderness lifeguard ski patrol realm. Then I worked as a paramedic for 17 years, and then I went to PA school and partnered that with healthcare management. Today I work in emergency medicine and internal medicine, and these areas are very different, but they're similar in that we cover a broad scope of medicine. I don't do the same thing every day. I'm autonomous in both settings, meaning I get to work on my own. I don't have to work with a physician. I get to make all my own medical decisions. I write all my medical orders. I write all my own prescriptions. I take care of my own patients. I do acute care and I do chronic care. Acute care is more on the lines of I'm seeing patients who are sick or injured today. They may have a sudden onset of symptoms, whether it's chest pain, abdominal pain, back pain, broken leg, trauma, lacerations, or in internal medicine in the clinic, I do chronic care, which is more along the lines of managing hypertension, managing blood pressure, cholesterol, diabetes, thyroid, a lot of things you may or may not be familiar with through your own personal family history if you have parents who go to the doctor for various illnesses, including asthma, breathing, pretty much anything you can think of I probably have seen in internal medicine and in my acute care. We do all disease processes in these settings, and that's why I like my two settings. In emergency medicine, I'm actually in the hospital in downtown Denver. So I do everything from heart attacks to abdominal pain, strokes, women in labor, trauma, injuries, car crashes, falls from trees, sporting accidents, urgent care where people have more like the sprained ankle, sore throat, strep throat, sinus infection. The company I work for, I also have the luxury of participating in virtual health, which before COVID was a small niche. And now it is a booming, growing field of medicine, and telehealth is becoming huge. So our telephone triage program has exploded and gone through the roof in the last 10 months. And I've enjoyed that opportunity to provide telephone triage to many more people. In my department, we also do a lot of the cleanup work for laboratory and radiology callbacks. When a patient has tests done, sometimes they will be discharged from the emergency department and go home before all of their results are finalized. If they're not sick enough needing to stay in the hospital, there's a variety of reasons they might leave before we have all the results. Or sometimes we will get results that take multiple days to come to completion. And so we have to call people back several days later to follow up on blood cultures that are growing in a scientific lab petri dish for multiple days. Or we'll have radiology images that are being reviewed by a specialist and double checked, and we will call them back to see how they're doing. Other things in the emergency department, where I work, our scope is very broad. I'm lucky that the doctors I work with give the PAs complete autonomy. We all do the same work. We do not handpick which patient is seen by which kind of a provider. This varies from hospital to hospital across the country. And in some emergency departments, the PAs will have a very specific area that they do minor injuries and illness, and the doctors in the emergency department will do the more serious ones. Where I work, we don't have that division of labor. We all see everything. Another thing I like about the emergency department in emergency medicine is I work shifts. So I have a 10-hour shift, and I show up, I work for 10 hours, and I leave. So it doesn't really matter how busy the hospital and the waiting room are, because when my shift is over, it's over. I work overnights, I work weekends, I work holidays. It can be challenging to balance our schedules with the real world, but it can also be really rewarding because I also have family. And so I can adjust my schedule for my family needs and not be pigeonholed into Monday through Friday. I can, take off a midday week from work if I have a family event going on. So I like the option to be able to work 24 hours, 7 days a week, 365 days of the year. It gives us a lot of flexibility. Comparing that to internal medicine, that's in a clinic, which is traditionally Monday through Friday. I don't work there full time, so I only see patients in the clinic a couple days a week. You're probably all familiar with clinic medicine if you've ever gone to the doctor for your sports physical, or you've been sick, or you have family members who you go in for your, somebody who's sick, and you all go as a group because you're with your parents and you get dragged along. In the clinic, we do appointments, we manage chronic illnesses. Here's some more acronyms for you. HTN is hypertension, HLD, hyperlipidemia, diabetes mellitus, TSH is a thyroid stimulating hormone, rheumatoid arthritis, and the list goes on and on and on. So like I said, there's very few things that we would not see in our internal medicine clinic. We also see urgent care sick appointments for patients who call because they woke up sick today or they felt sick last night and they need to be seen to help them get better. We also do physicals, immunizations, vaccines, and evaluations for pre-op, which is before somebody goes in for surgery, whether it's elective, maybe a orthopedic hip or knee surgery, or it could be something more complicated regarding heart, stomach, or other more in-depth surgeries. We do the evaluation before they go in for the surgery. We do a lot of procedures in the clinic as well, dealing with asthmatics and COPD patients who have difficulty breathing. We do breathing tests called spirometry. We do EKGs, which looks at the heart for anybody with heart conditions or chest pain or other reasons that I would need to have an EKG to evaluate their health. We also do your strep throat tests, flu tests, and now today we can add in COVID testing. I already mentioned the typical business hours of a clinic. Unlike my shift work, clinics can be longer and you have less control of your time because you might have to stay late or finish charts or stay with a patient who came at the end of the day for that last appointment of the day. Somebody has to take call for the clinic, depending on who you work for. You may be on call after hours from home. And otherwise, as I was saying earlier, the pros and cons of the ER, it's the same with the clinic. Some people like to have a Monday through Friday schedule and be off on the weekends and holidays. So that can be beneficial. For me, I like the flexibility of part-time in the clinic and the rotating schedule of the hospital and the ER, because that meets my family and my personal needs the best. All right, let's move on to some actual care of what we do. So I put in some slides, and we'll show you, since this isn't interactive this year, I will have to just pretend that you're interacting with me. I would typically ask, what do you see here? And what you should be seeing are bones and splintering broken bones. This is actually the picture of an elbow, and the long bone coming to the top of the screen is your upper arm, your humerus, and then the elbow is the joint where all the bones come together, where you see like the hinge. And then the two other bones are going to be your forearm, your radius, and your ulna. And this particular picture is of a gunshot wound where a person was shot in their arm through the window of their car in downtown Denver. And the bullet went through their arm, splintered their forearm bone right below the elbow. And those are the fragments that are embedded in the skin. So there's actually no holes or bleeding of the skin. There was just a very small entry wound where the bullet went in, and it ricocheted out the other side. But the broken bones are what we see on x-ray. So this person didn't have to go to the OR. Next is a very common injury on the left side of your screen is the before, and on the right side of the screen is the after. And when I say that, I mean before is when the patient came in before we treated them and tried to realign their fracture. This is called a distal radius fracture, also known as a broken wrist. And it's where the forearm, your arm, meets your wrist bones. And in the wrist, you have many bones. And typically this happens from falling on an outstretched arm while running, slipping on ice, sporting injuries, catching yourself rollerblading and falling backwards, trip and fall at home over an obstacle on the floor and putting your hand out to catch you. We see a lot of these year-round, winter, snow, and ice. We see them at sporting events. We see them with older people with osteoporosis. And we see them just for the freak accident because somebody trips and falls, and our instinct is to catch ourselves. So we inject the wrist at the broken bone fragments that you see on the left side and create a very numb wrist and hand, so it makes the pain go away. And then we manually manipulate the broken bone fragments and pull with some traction using our hands against their arm while another person is holding their arm, and lengthen the bones and straighten out the fracture fragments, and then splint it, almost like a cast, but not quite as tight as a cast. And so in the x-ray on the right, you see the outline shadows outside the arm are actually the cast material on x-ray. And hopefully you can see that there's improved alignment of the bony fragments. However, this person probably still will need to see an orthopedist and have surgery to fix the fracture in a very stable place so it can heal. Okay, so here's a case study for you to think about. This would be typical of PA school or EMT or paramedic school, where you're told a story and you have to figure out what's going on. So I'll follow up this story with the picture. I had an 8-year-old male come into the ER after he fell from a tree at a barbecue. He was complaining of his arm hurting, and his arm visually looked crooked. No LOC means no loss of consciousness. He did not have any head, neck, or back pain. And this is relevant because if somebody falls from a tree, I have to consider the mechanism of what caused their injury and what other injuries might they have. So he obviously has a broken arm from me seeing the deformity that I'll show you, but I also had to make sure he didn't have a more serious injury like his head, neck, or back, or chest, or belly, because those are vital locations that you can have injuries that are more dangerous to your life, versus a broken arm is dangerous to your limb, but less concerning for survival. So here's his x-ray. He snapped his arm in half right above the elbow, and the upper arm humerus is almost poking through the skin. You can see the sharp fragment there pointing up towards the skin. It was not broken through the skin, but I could visually see that it was pushing on the skin, creating a tent in the skin, which we call tenting. And he went off to Children's Hospital for emergency surgery. All right, next one is a picture of the lower body. And this is of an elderly woman's hips. And this is to illustrate osteoporosis and hip replacement surgery. You can see a lot of things in this x-ray. The top of the screen, you see screws on both the left and right sides of her upper hips. And these are actually from her back surgery. She had her lower back screwed and fixed because of her osteoporosis and her failing bones in her spine, in her hip. Then right and left, we have to talk about. When you're looking at x-rays, it's as if the patient is standing in front of you looking at you. So the right side of the patient's body is the left side of our screen. And there you see the very shiny, smooth ball and stick, which is also called ball and socket. That's the artificial hip that was put into this woman's hip many years ago. Then again, facing us, the left side of her body, her left hip, is your right side of the screen. And you can see it's very hazy and not well-defined bony structure there where the leg meets the hip. Because she has such terrible osteoporosis, the bone is essentially worn away and not there. She has very little support in her left hip. She has a lot of left hip pain. And this picture was taken right before she went in for a left hip replacement. All right, next is an x-ray of a child who swallowed 3 magnets. So looking at this x-ray, you see, if you've never seen something like this before, I'll describe. The center is the vertebrae of the spine. The horizontal shadows are the rib cage. And as you come down below the ribs, you can see the black circles that look like bubbles. Those are indeed air bubbles in the digestive system. And on the right side of your screen, you should see the 3 shiny objects that look like they're stuck together. And those are in fact 3 little magnets that he swallowed. And this child has to be admitted to Children's Hospital to be observed and make sure that they pass these magnets through their digestive system and the magnets don't stick to each other and pinch part of his digestive system together and cause something like a bowel obstruction. So this kid did just fine, but these children are observed in the hospital until we're sure that the incident has passed. Okay, another fun part of my job, so we've covered orthopedics in the body. Another fun part of my job is lacerations, trauma or cuts to the skin. This is common when people fall from bicycles, scooters, running, playing, kitchen knives, any sharp object, straight cuts, jagged tears, pretty much anything that you can think of that can cut the skin. Animal bites would also be included here. Hopefully it's not too disgusting to be seeing the pictures here, some blood, but it's pretty clean. This lady had just a simple trip and fall at home over a rolled up rug that she misguided her step and just tripped forward and fell and struck the edge of a piece of furniture. That's her forehead that split open. Your forehead is very hard. The skin typically tears across the skull, but the skull rarely breaks across the forehead. And otherwise her head was fine. She's had this large cut. So we just sew it back up. That's before and after. Doesn't take too long, maybe an hour, and this will heal just fine. Some other ones, this was a deeper cut, and deep cuts, as you can see, this is the leg and the knee, specifically it's the left leg, and this guy fell in dirty gravel and had some broken pieces of either metal or glass, he doesn't know what, but it cut up underneath the outside of his thigh. So the long suture that you see there with the rubber sticking out of each end actually tracked up underneath his skin and along the muscle of his thigh. And then he had the other couple little cuts on top of the knee and the little one in the middle. So we had to really, open up the skin, clean it out really well, irrigate it with some saline, some sterile solution, and make sure we got all the gravel and any foreign body out of there. Then before sewing it closed, I put in this drain. It's called a Penrose drain, and it's continuous from one end of the drain through the suture to the other, where the skin overlays the muscle and the fascia to help drain any liquid that will accumulate and prevent infection. And so I had him leave with his wound taken care of this way, and then come back in 3 days to have the drain removed, reevaluate the sutures in the wound to make sure it was all healing well without infection. Okay, moving on. This is a gentleman's, this was his left hand, I believe, yeah, left hand. And in the winter time, he was shoveling snow without gloves and slipped and fell and caught himself with a hand. And then he had pain in his hand for a couple of days. So he finally came into the hospital, and his palm was very red and tender. And I x-rayed it and could see something in there. And as I explored after the x-ray and opened up the cut, I could see this plastic piece that you'll see in the picture on the right. I pulled out of his palm. We don't know what it was. It looks like maybe a piece of a pen. And then irrigated very well, put him on antibiotics. This wound does not get stitches because we don't want to trap any deep infection in the hand. So he has to have really close follow-up and good wound care to make sure this heals without infection, because the hand is very sensitive to deep space infections in the tendons that allow you to move your fingers. So I had him follow up for the next couple of weeks to make sure this healed really well. Okay, another case study. This was a 38-year-old gentleman who came in complaining that his leg was cold and it hurt, but he really couldn't feel it that well. So it's kind of a paradox that it's painful, but it's numb. And VSS is vital signs stable. So he doesn't have a fever, his heart rate's fine, his blood pressure's fine, he otherwise is fine, except that his left leg, something is terribly wrong. And in fact, the next picture shows you something is terribly wrong. His circulatory system, this is taken off of a CAT scan angiogram, where we're looking at the abdomen, pelvis, and upper legs. And this picture, again, left is right, right is left. So the patient is facing us, and the right side of the screen is the left side of their body, and his left leg is the painful one that's cold, and the right side of the screen is, I'm sorry, the left side of the screen is the right side of his body. So the white illuminated structures are his circulatory system. So you see the aorta coming down from the center of the chest and splitting out to both kidneys on the right and the left. And then it continues down his iliac arteries on the right side, servicing his right leg. But as you see on his left side, the right side of our screen, it does not continue down because the blood circulation is completely obstructed to his left leg, which is why his left leg was painful and cold to touch and a little bit numb. So this was an emergency vascular surgery. Turns out he had a blood clotting disorder that he did not know about. That was a hereditary disorder that was a complete surprise to him at the time of this visit. And he needed to have a lot of medications, blood thinners, and long time in the hospital to make sure that he didn't have blood clots to other parts of his body. Okay. EKGs, I mentioned these earlier. This is squiggly lines that represent your heartbeat. This is a normal looking EKG. The spikes are the heart rate. We have a way of calculating these. So this one, we would say this heart rate is about 90. And when we do an EKG, we're looking at the heart from different angles. So there's 12 different views. So we're looking from the top and from the front and from the back and from the sides and the bottom and diagonally. We look at the heart in many different directions to see all four chambers of your heart, the atria, the ventricles, right side, left side. And so this is normal looking EKG, and no concerns. Then moving on to the next one, you can see the spikes are closer together. The heart rate here is closer to 100. If I go back, you'll see these are tall, skinny, and narrow. And on this page, they're tall and wider. And then the ups and downs, there's a lot of different ways we interpret EKGs. So this person probably has some sort of heart disease. Okay. Another case study, 51-year-old male. Back to our acronyms. We do everything by acronyms because it would be too long to write out all of these words. 50-year-old male complaining of shortness of breath, dyspnea on exertion. Dyspnea means difficulty breathing while exerting himself. So while walking, going up and down the stairs, bringing in the groceries, taking out the trash, just doing your daily activities, he becomes very short of breath. So short of breath, dyspnea on exertion for a month, and has also gained 20 pounds of body weight. Blood pressure, 132/80. This is a normal acceptable blood pressure. P is pulse, heart rate of 94, which is also acceptable. And respiratory rate of 22, which is a little bit high. His oxygen saturation is 72% on room air, and that's low. we want your oxygen to be above 90% and preferably higher, like 94, 95, 96. Put this patient on oxygen. His oxygen improved to 94% on 6 liters through a non-rebreather, which is the mask with the bag that hangs off the bottom that gives him high oxygen. And then on his exam, he has bilateral lower extremity pitting edema, which means his ankles are puffy, his calves are puffy and a little bit squishy. And this scenario all put together is a description of a patient who is experiencing what we call congestive heart failure, CHF, where your heart is failing to pump the blood out of your body as efficiently as it's coming in. So as the blood comes into the right side of your heart, it has to go through your lungs, get oxygenated, and go out the left side of your heart back to your body. But when a person experiences heart failure, the blood does not get pumped out of the heart as quickly as it's coming in. So it backs up a little bit into the lungs. And so it's a little bit like drowning, where you have extra fluid in the lungs, which causes this shortness of breath. It then backs up out the right side of the heart back into the body. And these people develop puffiness in their feet and their ankles, which is the bilateral lower extremity pitting edema. And they then start retaining water and holding on to that weight. So he's gained 20 pounds of weight over the past month. So this patient will need to have some heart tests done, an echocardiogram, ultrasound of their heart, evaluation of their kidneys and their body's ability to pee off extra fluid. They'll probably put on medications to help improve their heart contraction to get the blood to go out of their heart more efficiently. They'll probably be put on medications to help them pee off some of that extra fluid to decrease the workload on the heart. And then they will start to feel better. Their lungs will clear up, their shortness of breath will go away, they will lose some weight, and they'll be able to have more oxygen in their body. Alrighty, so I think that's all I have. So thanks for watching. I would typically take questions right now. So I believe the way this goes, if you do have questions, you'll send those to Mr. Stirrup, and then he and I will somehow figure out how to.
I have a place where I embed the videos. I'll have a place where they can put the questions, and then I'll wait till after your video has been watched, about a week, and then I'll copy and paste any questions. I'll email them to you, and then put your responses back up on the page.
Okay, so are we done recording?
Yeah, I can stop that right now.
Okay.